All right, let's go to specific interventions now for hypovolemic shock. Here are risk factors. These are the possible causes of hypovolemic shock. So any fluid and or blood loss. Okay, so we have absolute and relative fluid losses listed here. Management, of course, is based on what is the cause. So for instance, back here on chart 11-3, so if it's trauma, so that involves blood loss, right? So that will include, of course, surgical management of the injury. If it's surgical blood loss, then that means we give blood products and so on. So vomiting, you manage the cause of the vomiting. Why they're vomiting? Is it an ulcer? Is it viral or bacterial gastroenteritis, for instance? So that's the management. But for the shock itself, other than managing the underlying cause of the hypovolemic shock, is simply fluids and or blood products. Now, in the case wherein the patient's MAP fails to reach 65 or better, despite fluids and or blood products, then the patient may receive vasopressors, okay, as mentioned previously in the previous page, I mean. All right. But that's basically the management. So we give circulatory support, oxygen, just like under general management, but then the overall goal would be, of course, treating the underlying cause as listed in chart 11-3. And here are the fluids. So no different than what was mentioned previously. So we use crystalloids, which are saline and or LR, and of course blood products. Now on your blueprint here, for exam 1, it will include indications again. You remember the chapter on blood transfusion during your presentations? So they will include the table wherein you're asked about the indication for each blood product, meaning who gets fresh frozen plasma, who gets platelet transfusions, who gets packed red blood cells. Remember that table? So same question since it's included in the management here. Okay, so expect the same questions. And of course, the procedure for blood transfusion. As I mentioned, for pharmacologic therapy, it will be specific to the cause. For instance, diabetic ketoacidosis was listed as one of the risk factors, right, for hypovolemic shock. So therefore, what were the drugs? No drugs besides IV fluids. It was regular insulin, right? And that's it for hypovolemic shock. Any questions? Okay, let's proceed. For cardiogenic shock, I will just discuss this lightly because the detailed management or discussion of cardiogenic shock will be another chapter that will be for next week. Acute coronary syndromes. It's an entire chapter, so we won't do that today. Anyway, since cardiogenic shock underlying cause or risk factor majority is MI, so that's the reason why we'll discuss ACS separately. Okay, so I'll just skip through this one because this is again an entire chapter, right? But we'll go back to ACS. No, we'll discuss ACS next week. Okay, so I'll just discuss the part wherein it discusses the cardiogenic shock itself. Okay, so this part, the only cardiogenic shock part is under pharmacologic therapy. Okay, so the patient is considered to be in cardiogenic shock when they meet certain criteria. So let's discuss the, okay. The only really criterion for cardiogenic shock is the patient's MAP is now below 65. Then the patient is in cardiogenic shock. But remember, shock, is it a primary? Is any shock a primary diagnosis? No, it's always something else, right? And then they have a secondary diagnosis of shock. So same thing here. So patient is in cardiogenic shock. We have to treat the underlying cause. In this instance, like I said, it's usually a heart attack. So manifestations, of course, the only thing different here is the MAP, right? Because the manifestations, of course, it will be the manifestations of the heart attack or the dysrhythmia or whatever. And then the patient is in a state of cardiogenic shock because the MAP is now below 65. So next is we'll just discuss the pharmacologic therapy. As I mentioned, is fluid therapy really here indicated? No, because the patient will be in fluid overload. I'm not saying they'll receive zero IV fluids. They can receive IV fluids, but not the same IV fluids mentioned in hypovolemic shock, wherein we're talking 1 liter or more per hour. This one, maybe 30, 50 ml per hour, right? Just gentle hydration for obvious reasons. So here are the drug therapy you expect to give for cardiogenic shock. So most of them are inotropics as well as vasodilators. Now, very rarely the patient may receive orders for vasopressors, but like I said, rarely, okay? Because the effects of vasopressors is what? What will happen to the heart workload if you administer vasoconstrictors? It will increase it. So afterload increases, so obviously that's not good, right? So patients will have inotropic agents instead, as well as vasodilators. So here, most common inotropic will be dobutamine. So this stimulates the heart, increasing the strength of muscle contractions. It therefore improves cardiac output. But of course, there are consequences here because whenever you increase myocardial contraction, what are you doing to the myocardial oxygen demand? You're causing it to consume more oxygen. Okay, so therefore, of course, there are consequences here. So watch for chest pain. Those are the common complication or side effects of dobutamine therapy. Like I said, the patient will receive vasodilators. Now, although these are cardioselective vasodilators, meaning they usually target only coronary arteries, however, they will still have some peripheral or systemic vasodilation as well. Okay, but although not as common. Okay, nitroglycerin is more cardioselective. However, like I said, there can be some peripheral vasodilation as well. So dobutamine and dopamine. So here, dopamine is another vasoactive medication. And because heart attack patients will produce dysrhythmias, so they can be VFib, VTAC, or even AFib. Okay. So the medications will be medications we discussed already for module 8 last semester. We won't discuss the mechanical assist devices. These require in-depth discussion. For the intra-aortic balloon devices, ventricular assist device, we won't test that. These are ICU equipment only. Won't see them outside the ICU. Prevention, of course, is better. So here are ways to prevent. Basically, it's prevention of a heart attack, which means coronary artery disease diagnosis and management, which includes beta blocker therapy, statin medications, or anti-lipidemic medications, and smoking cessation, and remember the DASH diet. So that's part of prevention. And that's it. Any questions on cardiogenic shock? Okay. All right, let's look at the 3 distributive shock one by one. What are the 3 again? Septic, neurogenic, and anaphylactic. Okay, so this won't be long because these are very short topics. And since they're emergency, so therefore, do you have an entire hour to manage it?
No.
No, we're talking minutes, literally. With the exception, of course, is of septic shock. So septic shock will be separate. Let's do it now because it's the first one that came up. So septic shock is, as mentioned here, the most common. It also has one of the highest mortality because of the deceitful nature of the stages. So we'll talk about the stages of sepsis and septic shock, and why it's different than the all other types of shock. So okay. So we've discussed already the stages of shock earlier that applies to all other types of shock. So we have um, progressive, no, compensatory or non-progressive. And we have the progressive stage, and then we have the irreversible. So what happens to MAP as we go through the stages? It drops, follows one predictable pattern, correct? So everything was based on the patient's mean arterial pressure. So we know exactly if the patient is progressing through the stages or if we're stopping the um, the underlying cause. So it was easy to see. MAP is the one thing that is consistent, right? As well as the lactic acid levels, of course. Lactic acid will be going the opposite, correct? So which way will be the pattern for lactic acid? Okay, it'll be rising. Okay, so lactic acid, lactate will be going up, right? Okay. Look at the second paragraph. So despite the increased sophistication of antibiotic therapy, the mortality rate of septic shock hasn't really changed. It continues to have a really high mortality, meaning the complications, namely DIC and ARDS, the chances of it developing in septic shock hasn't really improved. So we're talking pre-World War up to today, which is now 2024. So nothing really improved much in terms of increasing survival rate for sepsis and septic shock. So risk factors, we don't have, oh, we do have a chart. So here are risk factors for sepsis and septic shock. The number one is immunosuppression. So this is where HIV, cancer patients, and patients receiving treatment for cancer fall in. Okay, so malnourishment, that means this includes not only cancer, but also liver failure patients, alcoholics, they're all fall under malnutrition. And also invasive procedures, meaning minor or major surgical procedures, neurogenic, and for that's for septic shock. For neurogenic shock, this is almost exclusively seen only in spinal cord injury. Okay, so most cases of neurogenic shock are in spinal cord injury. However, spinal cord injury, when you hear that term, you're talking about trauma, correct? People who fall on horses or fell from ladders or from car accidents, correct? But this can also happen from spinal anesthesia, meaning when you receive an epidural, okay? So you can also sustain spinal cord injury there, especially if you, let's say, you had a spinal needle put in, and then within 24 hours from that, you were given an anticoagulant. So that can cause bleeding into the spinal column, and then eventually spinal cord injury. And finally, anaphylactic shock. Here are your, of course, these are usually food and drug allergies, correct? These are the most common. Then we have less common animal bites, for instance, like bee stings or wasp stings or snake bites. Okay, so those are the cases for anaphylactic shock. Right. Back to sepsis. So let's go to the um, pathophysiology / stages of sepsis and septic shock. So most cases start local. Okay? So you got a pimple and the pimple was in the wrong place. Let's say that pimple is in your groin or somewhere between your vagina and your rectum, for instance, a bad spot for a pimple. And then it gets infected, and obviously you did not confine it to that local area. So now the infection spread from a local area into the bloodstream. Another example is a UTI. A UTI, that's lower urinary tract, correct? It was either undiagnosed and therefore untreated. Now it swam up, the bacteria swam up into your bladder, then eventually made its way up to kidneys, causing pyelonephritis. Then eventually you had sepsis, okay, went into the bloodstream. Another example, pneumonia. So pneumonia, local infection in the lung, correct? And because of the vascular nature of your alveoli, the infection can enter the bloodstream easily. Then, therefore, you have sepsis. Okay, that's usually the most common cases. Okay, so it starts as a local infection. Other sources of infection are, of course, um, either diabetic ulcers. You've seen diabetic ulcers, those in the foot, in the heel, on the toe. So patient develop osteomyelitis, infection of the bone, and then eventually sepsis as well. So same thing for pressure injuries, etc. So everything usually starts local and then escape local control, then went systemic. Okay, so now you have sepsis. The problem with sepsis is now when you enter the second stage of sepsis, which is usually SIRS. SIRS stands for Systemic Inflammatory Response Syndrome. Okay, so first stage again is early sepsis, and then next would be SIRS. When we say SIRS, this is we have criteria. The doctors will use a SIRS criteria to score whether or not you meet sepsis criteria. So SIRS involves a series of numbers. Let me show you online. It's actually a long list, but I'll show you a shorter, more a shortcut list. So here they are. So you're considered sepsis when you meet certain okay, so here. So these are just a few. It's actually a longer list than this. So you've got a fever, heart rate, respiratory rate, white blood cell count, and the others are PTINR, elevated PTINR, lactate levels increase, glucose increase. Okay, so it's a long criteria. So you meet a certain score, then the doctor will diagnose you with sepsis. Okay, so as you can see, let's say your problem was pneumonia. Does any of the things I mentioned look like pneumonia to you? The increased PTINR, is that consistent with pneumonia?
No.
Not at all. The lactate level increase, is that pneumonia? The BUN creatinine increase, is that pneumonia?
No.
Okay, so how about this one? So maybe, yeah, maybe the fever, maybe the WBC, respiratory rate or heart rate, but not the other things I mentioned, correct? But if you have them and then you have pneumonia, then that means, is the infection still in the lung? No more. Okay, so the other criteria mean that this has now spread and affected other organs. Okay, meaning the patient already has sepsis, therefore, at the cellular level, it wasn't manifested, but the blood pressure was already low for a considerable length of time that it already damaged several organs. Okay, so that's how complicated sepsis is. And then again, to meet the diagnosis, the doctor will assess you for if you met SIRS criteria. Does that make sense? Okay, so once you meet SIRS criteria, then they diagnose you with sepsis. Okay, and then we have protocols to follow after that. We'll look at it under management. Okay, so I'll show you what doctors will order once they get a diagnosis of sepsis, and they have to be accomplished on the first hour, another set on the third hour, another set on the sixth hour. Okay, so it's very strict because sepsis is the among the three distributive shock. This is the most common and also one of the most fatal. Okay, high mortality. And who are at risk again for sepsis? Older people, immunosuppressed. So think about the survival chances of these patients. They already have these risk factors. So you think they're likely to survive sepsis? No. So that's why we implement certain aggressive interventions once we make a diagnosis. Okay. So what happens after this is, of course, the patient's immune system is activated, correct? Now, the best way I can describe this is our body is not very good at responding to something life-threatening, such as sepsis. We respond in a self-destructive way. Let me show you why. Yes, this is normal. We release biochemicals, right? So in order to stimulate the immune system, we stimulate inflammation, correct? So by inflammation, we mean we release vasodilators, correct? Inflammatory substances. So to activate the lymphocytes and all the immune system cells. This part though, the biochemical cytokines and mediators, pro-inflammatory cytokines, sometimes are unregulated, meaning the body does not know how much to release. As a result, uncontrolled amounts of these cytokines and pro-inflammatory mediators result in increased capillary membrane permeability. They make the capillaries leaky. Okay, so once they become leaky, there are consequences to this response, because now remember that your lungs are made up of alveoli, which are wrapped in millions of capillaries, right? So when those capillaries become leaky, therefore, because of these pro-inflammatory cytokines, they leak proteins, they leak large molecules like sugar. So of course, what will happen to plasma? Since plasma contains those very large molecules that I mentioned, so therefore, will water stay in the capillaries or leak out along with those? Okay, it will also leak out. So that's why this is described as capillary leak syndrome. So now your lungs fill with water, exactly how the same reason which will cause ARDS. Okay, so this is now the consequence. Okay, so capillary instability and vasodilation interrupt the body's abilities for adequate perfusion. Therefore, what happens to the blood vessels? They dilate, right? So because of this systemic vasodilation, what happens to blood pressure? It drops. Okay, and then there's nothing we can stop that can stop this process. This is just how the body responds. So you recall 4 years ago, during the height of COVID, most people, or actually none of the people died from COVID. They died from sepsis and septic shock. This is the technical cause of death, right? So COVID simply was the trigger for pneumonia, right? I'm not saying you didn't, COVID had nothing to do with it. COVID caused pneumonia, and then pneumonia caused sepsis, and then patients died from septic shock, among others. So of course, what did I say at the later stage of shock? What do the patients develop during the irreversible stage? Or even the progressive stage, DIC and ARDS. So complications increase the patient's mortality. Okay, so the septic shock, and once they're there, they have DIC also, they have ARDS also. So complicating the patient's diagnosis. Any question? All right. So this part here describes the DIC formation or DDIC, and also because of the capillary leak, think ARDS is also developing. All right. So here are the consequences of the sepsis. So as the blood pressure drops, of course, the multi-organ hypoperfusion starts. Okay, so just like the other types of shock, this will cause liver, kidneys, the bowels, the skin. Okay, so the multi-organ failure starts. So here are the costs again. Part of the reasons why PT-INR, your bleeding times increase because your bone marrow is also affected here. Because remember, bone marrow needs blood supply as well. So your liver fails, resulting in decreased clotting factors. Now platelets drop. And again, because there's little to no blood flow to the pancreas, insulin levels drop, blood glucose levels rise, and because of the ongoing hypoperfusion at the cellular level, so lactate levels accumulate because of the anaerobic metabolism, going to lactic acidosis, and hypokalemia ensues. So to help doctors identify, because remember this, all this here, especially this part, okay? In early stage of septic shock, BP remains within normal. Patient may be hypotensive but responsive to fluids. Heart rate increases, tachycardia, hyperthermia, fever, bounding pulses are present, right? Okay. So what did we give the patient at the moment? So let's say here, let's put it right here in our comparison. So let's say Nolasco was admitted for UTI. Okay, so let's say Miss Nolasco is 89 years old from a nursing home. She had UTI. So what did we give her when she came to the ER? Antibiotics. We started it right away, right? So of course, yes, initially her MAP dropped Yeah. So let's say this is early sepsis. And then so we gave her antibiotics, right? At some point. And then it's mentioned here that the patient had, what did the paragraph say? Patient, the BP is still within normal. No, hypotensive, but then responds to fluids. Okay? And then the heart rate increases and there's flush skin, right? So what did we see in the other types of shock? They had cool, clammy, right? But hers is, she is flushed and warm because what's happening here? Is there vasoconstriction? No, she has vasodilation. So instead, this part here can be confusing because you gave her antibiotics here, correct? So will you see her skin color, her blood pressure, which is no longer, because she responds to IV fluids. So this rise here, do you consider this a improvement or a deterioration? I mean, looking at her, because we gave her antibiotics. So this is now 1 to 2 days. So would you say that her improvement is a deterioration or a improvement? Yeah, you would say, oh, she's improving, right? Because she's responding to, we would say she's responding to the antibiotics. Yeah, of course, this is an improvement. However, is she really improving? Now, to tell whether or not she's improving, doctors will have to monitor procalcitonin, CRP, and also activated protein C. Although protein C is more expensive, we usually just order procalcitonin. This will do just the same. Okay, so what's the different? What's the significance of procalcitonin? So procalcitonin as well as activated protein C are substances that prevent inappropriate clotting. So therefore, if these levels are low, what's happening to the patient? Is she really improving? No, she's getting worse. Okay? So if a clinician is following the patient for sepsis, this is what we'll monitor the patient for to ensure, is the patient really improving? So we have to watch that part to see if this is really an improvement. So if the procalcitonin levels are abnormal, is she really improving? No. So that way, do we stop our interventions or do we become more aggressive? We have to treat her more aggressively. If the procalcitonin levels are high or are abnormal, then that means she could do this. She could drop just like that. Okay, really quickly in a matter of hours, right? So that's what makes. Plus, the patient also feels better, okay? Especially if you're giving fluids, you're giving antibiotics. She feels better. But if the procalcitonin levels or CRP levels, ESR, as well as the activated protein C are abnormal, she's not getting better. Okay? She's actually progressing towards septic shock. Okay? She's going to die. Sorry. And then remember, the patient is hypoperfused, right? So do they have AKI at the same time?
Yeah.
The patient is in AKI also at the same time. So there are things beyond what is just discussed because this is just shock. Okay, so the AKI is a different chapter. So that's a totally set of management there, okay, for AKI. There, so if the patient does not respond to therapy, patient will go into septic shock. So remember, she started with warm flush skin, right? So therefore, the unlike other stages of shock wherein she started with cool clammy, so she will be warm and flush, and then later as she gets worse, then she goes into cool clammy. But it's later in her case in septic shock. So management. So we have a bundle. So we have Joint Commission has standardized care. So the moment sepsis is identified, we perform the following. So as I said, Joint Commission implemented core measures, okay, together with CMS, Center for Medicare, Medicaid. So we have sepsis bundle. So it's a chart here. I'll go back to this paragraph. Let me just show you the chart. Okay. So within 1 hour of diagnosis, this is in order. You cannot interchange this. Okay, this must be implemented in this order because otherwise you'll mess it up. First, you draw blood, lactate, and also cultures. Okay, draw blood first. That's the first thing you do. So let's say that takes 1-2 minutes, and then you start antibiotics. And unlike, you guys, you're still new. So how long does it take you to hang IV antibiotics? It depends, right? Okay, so, but, once you're experienced, this will take like, the whole thing will take probably 3 minutes. Okay, it's already started. So a few seconds to draw blood and then blood, lactate and then blood cultures. By the way, lactate will be it will be an ice specimen. Okay, so you put the chest tube in ice. Okay, not frozen, but just in ice. Okay, either a cup of ice or the specimen bag will have ice. Okay, and you take that immediately to the lab for the sample to still be good. Then blood cultures sent separately, and then start the antibiotics, and then the IV fluids. Fluids here can either be LR or NS, and the rate will be 30 ml per kilogram per hour. So if I weigh 170 pounds, how many kilograms is that? About 80 something, right? So 80 times 30, how much will I get? Over 2 liters in the first hour, right? So the heavier you are, of course, the more fluids you will receive, all right? So that's a lot of fluids, right? So what type of IV access do you need? Large bore, right? Or if you have a central line, even better. Now, if the patient remains unresponsive to the fluids, then we will start Levophed. We will start norepinephrine, right? And this is the bundle, right? And then this is not one time. So on the next 3 hours, we repeat it. So if the patient still has the same, however, if it's within 3 hours, they probably will skip the first 2, but continue with number 3 and number 4. Okay, more antibiotics, more fluids, more vasopressors. Right, and then same thing. So 3 and then 6, we repeat it. Right, until the patient meets 65 MAP or better. Now, the first hour, this is what you do. This is the crucial part, first hour. And then you just continue. So if the patient does not meet this, you continue. So this first 2 may be skipped. The doctor will decide. Okay, so let's say you report, right? So you completed the bundle. Let's say fluids are ongoing. Then you report, hey, doc, it's not working. Okay, patient's still hypotensive. So they may skip the first 2. They'll say, their clinical decision will say, well, it doesn't make sense drawing another culture, but they may obtain lactate. Okay, so this part, the doctor has some they exercise judgment. Okay, draw another lactate, and then we'll continue with the other therapies. Okay, then they do the same thing until we meet our goal. So this is what I mean by earlier by 0.5 ml per kilogram, right? Instead of 30 ml per hour. Okay. So for sepsis, that's what we follow. Any question? So how do we know the patient is making 0.5 ml per kilogram per hour? What will be insert? The patient has to have a Foley. Okay, unfortunately. There's no other way. Do you have any other suggestion on how to measure this without a Foley? Impossible. Okay, so the patient has to have a Foley. Which makes it even more important that you do strict aseptic technique during insertion. Okay, so that's why we're on your ass when you do the skills. All right, because it's very crucial. Okay, so this is one of the indications that a patient must have a Foley. So the insertion part has to be done right, right? Because otherwise you're causing another infection. The patient's already here for sepsis. Okay, Nolasco's already, her life's already hanging by a thread. Then you're gonna cause a UTI because of poor insertion technique. All right. So just like any other shock patient, so don't forget nutrition, feed her, right? And then watch again. So if we have, because we have a Foley, so what was the bundle again? We learned last semester under module 9 for UTIs. Now for CAUTI. CAUTI, yeah, CAUTI. Catheter-associated urinary tract infection. How do we prevent that again? Okay, wipe from, you do Foley care, right?
Yeah.
Hospitals now have kits, they have certain wipes that you follow their instructions, how many wipes to use and how to do it, right? To do catheter care. Question, how often do you do that? Could be a NCLEX question. How often do you implement the CAUTI bundle? Not really every time you turn. No. Every what?
12.
She said every 2 hours. No. Yeah. Okay, at least once a shift, but also the book says another thing. What about if the patient has a bowel movement?
Oh, yeah.
Yes. Okay. So the answer will be every shift and every after bowel movement. So if the patient has a bowel movement, whether female or male, do the CAUTI bundle again. Okay, so you wipe again. Are we clear? All right. Best thing for me really is soap and water. For me, that's better than the antiseptic, okay? Because you're washing it, okay? So you use soap and water, it runs, right? So it washes off the organisms. But if you use the wipes, yeah, that's evidence-based. And here are more patients with high risk for, in addition to the chart 11-3 earlier. So you've got here extensive trauma, burn patients, or diabetic patients. Also high risk. Not testing SOFA because this is for the doctor only. We're not the ones scoring this in practice. It's the doctor that scores the sepsis. Any question on sepsis? Very good. Let's go to neurogenic shock and then finally anaphylactic, and then we're done. Neurogenic shock. So what's the risk factor again? Who gets this? Spinal cord injury. Okay. So this occurs during the first 24 to 48 hours after spinal cord injury during the acute period. Now let's go to how do we recognize it? So the manifestations, there are 3. Oh no, that's thinking about autonomic dysreflection. Okay, so this is for all spinal cord injury patients, so they're at risk for neurogenic shock. So here are your characteristics. Okay, so one is bradycardia. So this is a little bit of trivia. All other types of shock have tachycardia, correct? This one is the only one that has bradycardia. And of course, there's hypotension here. That's the other manifestation. So you got hypotension, bradycardia, and the third is respiratory depression. Okay? Patient will have difficulty breathing. And these are the other manifestations. But of course, it's not exclusive because where else did we see warm, dry skin? Rather than pale, cool skin, septic shock, and also later when we go to anaphylactic shock, it's also seen there. Okay, but for neurogenic shock, that's it. You have hypotension, you have bradycardia, then respiratory depression. So management, let's go straight. What do we do? Actually, we give fluids. Okay, so fluids is the first intervention, followed by vasopressors. So we give norepinephrine. And what do we do about the tachycardia? I mean the bradycardia. What drug was given to raise heart rate? No, module 8 last semester. What was that drug? Atropine. Okay, so anticholinergic atropine. So those are your treatments. That's it for neurogenic shock. This is an emergency, so you give fluids. Okay, interventions? Okay, fluids, followed by vasopressors, then finally atropine for the bradycardia. Any questions? All right, that's how you take care of neurogenic shock. And the rest, of course, there's management for, we'll discuss spinal cord injury separately later in the semester under intracranial for exam 2. Finally, anaphylactic shock. What's the risk factors again? We've got food and drug allergies, then we got bee stings, whatever else you're hypersensitive to, including latex. Okay. So what happens here is the patient has a massive amount of histamines, cytokines, right? And then what will be the patient's manifestations? Besides hypotension, so what are the early signs you see? Okay, so there's headache, lightheadedness, nausea, vomiting, and then when there's angioedema, okay, so your angioedema is your blood vessels get swollen, then you have that causes redness and inflammation, right? So your face swells up or whatever other part of your body, you may or may not have some rash, hives, urticaria as well. And then the more life-threatening symptoms, of course, are the bronchospasm. Okay, and now you can't breathe. So let's go to management. So once identified, you suspect anaphylactic shock. If it is at home, have them call 911, or if they're known to have hypersensitivity, then you must have an EpiPen, right? Unless we can't afford it, it's very expensive. Then basically call 911. Okay. So in the hospital, well, depends on the scenario. So usually in the hospital, it's usually caused by a drug allergy, correct? So what's the first action?
Stop the drug.
Stop the infusion of the drug. That's just like blood transfusion, right? You have a reaction, stop the transfusion. This one, stop the drug. What if it's a bee sting? Bite the bee. No. So if possible, you can see the bee sting, you remove it, right? If it's possible. If not, then just call 911. So what's the first intervention? Epinephrine first. So here. So epinephrine, IM or IV, followed by diphenhydramine, which is Benadryl. So IM or IV, and then albuterol. And then when all three are given, then the doctor may add steroids. Okay, but steroids are last because there's no such thing as a fast-acting steroid. Steroids are useless in emergency. Okay, so we'll give steroids last. So we need the fast-acting medications first. So what is the epinephrine for?
to stop the vasoconstriction.
Okay, remember, epinephrine will not stop the reaction. What is the purpose of giving epinephrine? To stop the
Histamine.
bronchoconstriction, right?
bronchoconstriction.
Remember, there's vasodilation. So epinephrine will cause what? Vasoconstriction. Okay, so this is the counteract. Because what's wrong? What is responsible for the bronchospasm, the swelling? Is it vasoconstriction or vasodilation? It's actually vasodilation. Why did the patient's throat close? Is it vasoconstriction or vasodilation? It's also vasodilation. Vasodilation leads to bronchoconstriction. Let me explain.
Yes.
The airway, our airway, the trachea, it's a muscle, correct? So what does a muscle have? Blood vessels, correct? Okay. So the diameter of any muscle, what happens to it when you dilate the blood vessels supplying it? It will narrow, correct? Because the opening will narrow because now the muscle will thicken, correct? Because if you increase the size of the blood vessels to the smooth muscle, so of course, what will happen to the diameter of that muscle? It will increase, it will widen. Now, if you widen, meaning, you thicken the, let me see if I can explain it this way. So if this is the thickness of your airway, it's supposed to be like this. Let's say it's paper thin. Now, if the blood vessels supplying this muscle dilate, what will happen to the thickness of this paper? It will widen the diameter of it will increase. So therefore, what happens to my opening now? This is where I'm breathing. It will close because now the walls are so thick. So the purpose of the epinephrine is to vasoconstrict the blood vessels. So if you vasoconstrict, of course, the airway will open back up because now you've constricted the blood vessels supplying the muscles of the bronchial tree.
So,
Does that make sense?
so when they give the epinephrine, right, if that actually causes bronchoconstriction, why are they giving that?
No, it doesn't cause bronchoconstriction. It causes bronchodilation by vasoconstriction. It's a different story, different term. Yes.
So why are they giving that?
No, epinephrine first, and then followed by.
Epi?
No, it's not albuterol. What's next? It's in order.
Epi?
What's after epi?
Benadryl
Benadryl next, and then albuterol. All right. Okay. So, what's the purpose of Benadryl? Because what caused the whole thing?
Allergy.
Hypersensitive reaction, right? So if you give Benadryl, so what will happen to what is Benadryl? It's an antihistamine. So what happens to histamine levels when you give a large dose of Benadryl? It will decrease. So therefore, the reaction stops. Okay, so therefore, the epinephrine, is that the only drug you give?
No.
No, that will only open the airway, doesn't stop the reaction at all. Benadryl must be given to stop the reaction, then followed by albuterol. So albuterol, think of it as, can you give epinephrine nonstop? No, that's harmful. So you can give albuterol instead. So because albuterol basically is the same, because epinephrine is a sympathomimetic agent. So what is albuterol? It's a beta-2 adrenergic agonist. So same effect as epinephrine. It's also a vasoconstrictor because what's the side effect of albuterol? Tachycardia, just like epinephrine. Same drug, same action. This is just inhaled, correct? It's a beta-2 adrenergic agonist. Okay. And of course, steroids is a long-term management so that the reaction is not likely to recur. Okay, so you give steroids. You may give another epi if needed. Say after 5 minutes, patient still has wheezing, you give another dose. Same thing for Benadryl. After 4 hours, may need another dose. And of course, if the patient get worse, let's say they go into cardiac arrest, then you have to do CPR. That's it for anaphylactic shock. And of course, after they survived it, what do we do to prevent the future? Allergy ban, okay, so make sure they have a bracelet or it's in their record, whatever they were allergic to. So that doesn't happen again.